time to get the show on the road. Welcome to a Menopause Doctor's A to Z of HRT with our host, women's health physio, Christine Bird, who's our clinical lead at Menopause Movement, and she's going to introduce today's guest, Dr. Karen Morton.
Thank you, Anne. That's a great start. Welcome to you all. Amazing to see so many of you. That's fantastic. So today we're lucky in the hot seat. We've got our trusted, legendary friend, Dr. Karen Morton. She is a consultant obstetrician and gynaecologist. She has a special interest, not just in the menopause, also in pediatric and adolescent gynecology. And she is on the specialist register of the British Menopause Society. Like Karen often talks about in her public talks as well, is we're always so welcome to listen to. Women's need for gynecological reasons seek medical attention obviously is higher than those of men. This care is often lacking, and Karen has an unwavering commitment to address this gender health inequality and the impact it undoubtedly has on career progression. So hopefully we'll get around this a little bit tonight as well. This was also one of the missions around founding Dr. Morton's medical helpline. We'll leave the details in the chat. Really check it out. It's an accessible, affordable, but also nurturing and high quality medical care service. All our members know Karen very well. Karen, like Anne said, delivers module 1 of our big course. She's by far our most favorite doctor, especially considering we're all about movement. When we used to talk at live events together, Karen would cycle from Guildford to Knightsbridge or wherever we would be talking, no problem at all. And what's always really struck me about Karen as well, that although you're an incredibly busy person, and I think it's something that a lot of women into the menopause struggle with, you're always so good at prioritizing what's most important, like playing golf with your friends. You know, certain things just seem to be a definite in your diaries, and that's always inspirational. So today we'll have addressed many questions that we frequently get from our members regarding HRT, and all of you towards the end will have a chance to put some questions either in the chat or Q&A, and Joe will let us know. So we're hoping that all of you that teach or train or treat menopausal women can confidently signpost with the information we'll be talking about tonight. So Karen, once again, welcome.
Thank you. Lovely to see you. Last time I came over, Christine, you may remember I got a puncture on the way.
Oh yes, you did. Last filming.
When we were filming this. Oh God.
But even then, you were still managed to do all these magical drawings of the reproductive system, despite all the puncture stress and everything else. Somehow or another, you always keep your calm. So shall we start with the most frequent question we often get on our members platform, as there is so much confusion about different types of HRT. What actually is the difference between bio and body identical, if there is any? What's evidence, what's marketing, and also the question of, again, how identical can it really be?
Okay. Well, of course, I'm in danger of getting on a few hobby horses. I do have a few hobby horses.
Good.
I'm a bit ashamed, if I'm absolutely honest, of the way that a number of doctors, other clinicians, how menopause has become a bit of a racket. Mm-hmm. And I was worried actually when I logged in that you were expecting me to give a slide presentation. I thought, oh, and I didn't think you were, but if I had been, I would probably have quickly opened up a talk that I gave very recently where the opening slide was a picture of Davina McCall saying Davina McCall has got a lot to answer for.
Yeah.
We'll come to that later. It feeds into the article that I've half written, which is entitled "All That Glitters Is Not Menopause."
Mm. Yeah. No, what now is referred to as the Davina effect.
Yes. Yeah. Anyway, but the difference between bioidentical and body identical, well, of course, all estrogen that is given as hormone replacement therapy is body identical. It is body identical. It's derived from plants. It's body identical. Every single HRT preparation uses the same estrogen. Maybe delivered differently, but it's the same estrogen. Of course, when we come to progestogens, it's slightly different. in as much as the term progestogen is an umbrella term for both natural progesterone and synthetic progestins. And we can drill down on the important differences in due course, but that's not quite the question you've asked me. You've asked me about bioidentical, which really by and large refers to bespoke little pellets to put under your tongue at huge, huge cost. And I'm afraid I can't see any justification for that sort of approach. It's not necessary. It's overly commercial and expensive. The British Menopause Society hold the same view. And I'm afraid I can't support that sort of therapy. That's more, it's pandering to people's anxieties of thinking that that might be something better. There is no proof at all. And indeed, it's entirely unregulated. So that worries me a lot.
Yeah, it's such a shame, because commerce and good practice can go together. But in this case, it's probably marketing without the happy win-win situation of commerce and good practice.
And very often it's not just the actual product, the delivery of whatever the woman is going to take that comes with that package, but very often a lot of unnecessary blood testing also comes with that package. I had a woman the other day who said she'd been having blood tests every 6 weeks to try and fine tune whatever it was. And I'm afraid that cannot be justified scientifically.
Yeah. Would you mind explaining why the blood testing, particularly in the perimenopause, is unnecessary?
Well, before the age of 45, of course, on the whole, menopause is uncommon. And so there can be some justification, and I may elaborate on who I think should be tested or not, but there could be some justification for testing as a baseline to try and make a diagnosis to see if there's some other reason why a woman's periods are infrequent or whatever before 45. But after 45, if a woman has symptoms that fit the possible range of symptoms of perimenopause, then it's not a mystery. She's 48 or whatever, and her periods are coming every 2 months, and she's got hot flushes. I mean, that would make life very simple. Of course, it may be that her only symptoms are low mood, or things I call not measurable things, rather multifactorial things. So you certainly don't need to measure before you start some hormone replacement therapy in that age group, if it's appropriate and if the woman wants it. And so the only time I measure after that is if they're on a perfectly good regime, which for 9 out of 10 women would suit them perfectly, and yet they're not getting symptom relief. Now, obviously, if it was hot flushes, then symptom relief means the hot flushes have gone. And if the hot flushes have gone, if there are any other residual symptoms like aching joints or low confidence, then it's highly likely she's absorbing it. Mm-hmm. So I often don't measure anything then. But say the whole range of symptoms that were worrying a woman were non-measurable things, then sometimes doing a blood test at that point is justifiable in order to be able to say, well, you know, your estrogen level is well up in the normal range. We're always aiming between about 300 and 500 picomoles per litre. There's no purpose in it being any higher. And so maybe one needs to step back and think, okay, my hormonal platform is stable. What are the causes of those other things? And there is a natural resistance to imagining that something might be a fundamental mental health problem. And so I usually say to women at that point, of course, I see as many 16-year-olds as I do 30-year-olds, as I do 40-year-olds with low self-esteem or whatever. So the blood test really doesn't contribute anything. So do you want me to keep talking, Christine?
No, that's very interesting.
Shall I?
Processing it really, because
yes,
I think...
No, I want to, so
yeah.
Moving on, because of course then a lot of women at that point will say, well, what about testosterone? Should I have testosterone for my low mood or my whatever? And I explain that testosterone has only been proven to be useful for low libido, low sex drive.
Yeah.
Although, interestingly, the British Menopause Society, as we speak, are launching a new randomized trial, which is good. I think it's a good thing.
Very welcome. Yeah,
very welcome. But so I say to those women that we do make androgen in our adrenal glands. We make dehydroepiandrosterone in our adrenal glands, and that is converted to testosterone. And having a normal testosterone level is good for us. But having a very high testosterone level is, well, we don't actually really know very much about whether it's good for us or not, but certainly under pathological situations where women have, for example, adrenal tumors that are making too much. We do see occasionally, male pattern baldness, hirsutism, virilization of various things. So I do measure a testosterone level, and that indeed is in the BMS guidance and college guidance. And if their testosterone is well in the normal range, then I say it's well in the normal range. I don't honestly feel there's any reason for taking any.
And is it correct, Karen, that also testosterone reduces at a much earlier age and is less related to the menopause?
Yes, it is. It's absolutely true. It has a
much more gradual.
It's a bit like for men, actually. Their testosterone reaches a peak at about 25, 26, 27, 28, and then comes down and then stays plateaued.
Yeah. Although I did read, there was I don't know if it was in the British Medical Journal, that at 70 it slightly goes back up again. I thought, well, that's something to look forward to.
Yes, well, maybe, but I have a horrible feeling, Christine, that the effect of that will be, maybe thinking that you want to just get back and find your best pair of eyebrow tweezers because.
Yeah, that's possible. I know this is a really big question, Karen, but could you briefly talk us through the benefits and risk of HRT? Because I know you have got such a balanced and also very philosophical view.
It's a philosophical issue, isn't it?
Absolutely.
And I come across women who approach this from such different personal philosophies. The women I feel most sorry for really are those. I had one today, a lady today who her menopause was at the normal time of 50, and she, in her words, but I knew the words she was going to say because I've heard them so often, that she wanted to battle through it, even though she was having really bad symptoms and really poor sleep, sweating like goodness knows what. And then so 3 years later, she decided she'd try some HRT. And that feels such a shame.
Yeah.
Because there is no way of knowing when those symptoms are very bad, how long they're going to last, whether they're going to get any worse, or they might last a lifetime. But the bottom line is that you could sort of divide it into age groups a bit. Of course, if one is unfortunate enough to have premature ovarian insufficiency. I don't know why we have got to call it premature ovarian insufficiency. It's premature menopause, but it's a sort of, maybe people think that sounds unkind. It's not meant to be unkind. It's just factual. And it's pretty uncommon, premature ovarian insufficiency. But it's obviously completely devastating if it comes before a woman has had her children. Absolutely. If she wants children, absolutely devastating. But it's also very harmful for her general health. So a woman whose periods stop and she is absolutely menopausal before 45, I think she should be well advised. I mean, there should be a really positive discussion with her about taking hormone replacement therapy until the average age, and then make a new decision. You're not committed. It's the whole of it's an experiment. And I say that to so many women, that life's an experiment. But as long as it's a safe experiment, then it's reasonable to, if you would like to do the experiment. But the way you phrase things to people, of course, and this must apply in all of your work, everybody on this call's work, if they're health professionals, the way you phrase it and travel with the patient, and you can usually help them to see what you feel is the best medical decision. And then, of course, in the end, it's their decision at the end. But okay, so the youngsters, of course, their whole body needs support. You've seen me give a talk endlessly on the benefits, Christine, so that the bees, the brain, the bones, the blood vessels and cardiovascular system, and the bits below the waist. So they're my 4 Bs.
Like that.
And all of them are important. And you don't really want to let things deteriorate before you try and grab them back and get them back on track. So there is a window of opportunity for maximum benefit for these things. So a timely discussion is a useful thing. Perhaps I should, may I very naughtily give a little plug for something I'm working on, which is, which you're probably aware of, Anne, Jo and Christine. I'm working with Adora to produce an AI-driven, conversational, personalized chatbot app, menopause app. Yeah. Which, if I have my way, if the Adora team and I have our way, will be sent to every woman at 45, happy birthday, by the government, by the health service. We're supposed to be a health service. Yeah. And it will help them to learn about, personalize it, be able to ask questions and get personalized AI-driven responses, to help them to see where they are on the journey and make good choices depending upon their own personal circumstances.
So it's so exciting, because AI, really the potential of it is.
No, it's really great. So the advantages are all those things I've mentioned. Probably I'll put those in reverse order, though. The bits below the waist first. Of course, it's very important that the bladder and the vagina stay healthy. And the number of women who, if you took the simplest example, not painful sex, put that to one side for the moment, but if you just took the simplest example of starting to need to find a bush because the bladder has become more irritable, and they're more vulnerable to urinary tract infections, and just those things, which will be very dear to you, to your heart, I'm sure, with pelvic floor. And indeed the pelvic floor itself, collagen, keeping collagen as coiled up as you possibly can within the pelvic floor, as well as elsewhere in our bodies. So that's all the bits below the waist. Then obviously the bones are absolutely incredibly important. And people will put lots of information, personal information, family history information into their equation as to when as to how they're going to move forward. So if they watch their mother get shorter and shorter with crushed vertebrae, and in pain, osteoporosis does run in families, there's no doubt about it. So that's another thing to put, and careful history taking with a woman can help her to see the importance of these various things. Women who've been on steroids for asthma a lot of their life, anything that's going to have reduced their bone density, they would be well advised to think hard about it. Of course, as far as risks go, I have to tell you that the risks are really pretty few. With body identical HRT, women really don't need to be worrying about breast cancer. They really don't. They should be worrying about breast cancer from the point of view of their general health and whether their weight is good. That's the biggest risk factor for breast cancer. We know that's the biggest risk factor for many cancers. And they can counterbalance any increased risk of the use of synthetic progestins by vigorous exercise, more than counterbalance it. So I think the risks are very much overstated. You may get me onto the topic of transdermal versus oral.
And we'll come to that, but what I'm so glad you just mentioned is the bone side of things, because that probably, if women should be worried about one thing, it probably is bone density. If you look at what happens to women when they have low bone density osteoporosis, and what happens if they may have a hip fracture, is often the end of their independent life, of their mobility. So I think if we're concerned about anything, let it be about our bones. And also it's modifiable. If we know, like you said, if it runs in families and your mother has osteoporosis, then you're a risk group, and we need to refer women for DEXA scans so much more often and be more preventative, because it's something that's so modifiable.
Absolutely. I mean, you couldn't get harder evidence.
That's right. And it breaks my heart that so many women still are unaware. It's almost like you think, as we all have so many mammograms, why don't we all have more DEXA scans? Because actually that has a much greater impact on our health often.
I mean, of course, if women are going to take hormone replacement therapy, if that is their decision, then they probably don't need a DEXA scan. But it's really for the women who, for one reason or another, are deciding not to. So they should have they should be offered a baseline bone density, because the result of that may feed into their decision. So they can base it on hard fact.
Yeah, absolutely. And then also that combined with the highly evidenced bone strengthening through doing strength training, and how safe it is, even with low bone density. So, although we want women to be worried about it in terms of taking action, not worried as in it's a modifiable, it's something that
definitely
it can be helped.
I'm sure you do this, Christine. I advise all my ladies to walk with a little rucksack on their back, put something in the rucksack, always walk with a rucksack on your back. It's so much more mechanically fantastic and for your spine.
It's a nice simple way.
If you pass me on the A3, you'll find I've got some little hand weights in my car. I hate spending so much time in the car. I really do. But I have to drive up and down from Putney to Guildford. So I have now got little hand weights, and obviously an automatic car. So you'll see me sort of doing this because I can't bear having my son sort of flip my wings, and if he's sitting next to me, it's just too terrible. So I've just got to make these arms that bit better.
Right, we don't want muscle atrophy, we just want nice muscle bulk into our 90s preferably. Really.
Absolutely.
Right. So actually something you just mentioned, Karen, was topical for obviously urogenital symptoms of the menopause. It's a very big mouthful, and the terminology keeps changing as well, from vulva and vaginal atrophy. Why do so many women need treatments, and why are the bladder, vagina, vulva areas that get so impacted by hormones?
Well, I mean, I think it is absolutely inevitable that that they're not nourished. I mean, the vagina needs estrogen to stay nourished. And you've heard my analogy of it changing from being like seersucker, except young people don't know what seersucker is. So you have to think of it as cheesecloth, I think, probably. It's a bit, they might know what that is. But anyway, you know what I mean? Very nice, stretchy, wavy. The right term, of course, is rugosity. And it just changes at a different rate in different people. I see it sometimes in breastfeeding women. Because they, of course, are menopausal essentially, and the longer they breastfeed, the more the vagina becomes sad, pale, and sad, and dry and flat. But because we want it to be pink and plump and perky, don't we?
Absolutely,
lovely and wavy and juicy. And a lot of women are they're not counseled correctly about the treatment because they come and see me and they say, well, they were given this, but it was useless. And I say, well, how long did you take it for? How long did you put the pessaries or the cream in for? And they'll do it for about a fortnight, and then they'll be surprised that it's no better. But I say, well, it's not like an antibiotic. It's not a treatment. It's a nutrient.
Yeah.
And so your skin turns over from its bottom layer to its top layer. You lose a suntan in 3 months.
Yeah.
So the new skin is freshly grown from the bottom layer. And so it takes 3 months for you to see the benefit of topical estrogen in the vagina. I'm quite partial to prasterone, which is dehydroepiandrosterone given into the vagina as a waxy pessary, which you pop and it melts and it's absorbed into the vaginal mucosa, and intracellularly it is converted to estrogen and testosterone, and less than 5% of it gets into the general circulation. So it's very intracellular, which appeals to women who've had breast cancer. It's perfectly safe in women who've had breast cancer. And it appeals to other women. Some women look at the leaflet that comes with the cream and they say, well, I don't want to take HRT. And I say, oh, well, if you were to swim about in the cream for a long time, you could call it HRT, but it's not. It's just a local nutrient.
Yeah.
And I'm very against. We're still on vulvar vaginal atrophy, aren't we? So I can legitimately say I'm very against Vagifem.
And why is that? Is it environmental reasons?
Yes, it's environmental reasons. I cannot believe all that plastic.
Yeah.
It's just shocking. As if a woman isn't able to put something up with her finger. Quite ridiculous. So I'm very against that. So I do prescribe, if people want a little tablety pessary, I use Vagirux, which just has at least just one applicator for all the pessaries. I do, if I've got women who've got a ring pessary in, then I tend to use cream.
Yeah,
I like the idea of the cream sort of getting all around the nooks and crannies behind the pessary. And I do use Invagis, which is also a waxy estrogen pessary, which people put in and it melts. It's a slightly bigger pessary than the prasterone, the DHEA pessaries, and it does melt and sort of slightly come out on their pajamas, and so that some ladies don't like that and some don't mind it at all.
And will GPs prescribe that whole range, or do you think generally that's Ovastin and Vagirux or Vagifem?
No, I think they will definitely prescribe Invagis, but I don't think they'll prescribe prasterone. Yeah, it is that bit more expensive, and the manufacturers have this strange notion that it has to be used every night. The license is for every night, and I think that's a bit ridiculous. I think it's a jolly big ask for a woman to put something in every night, and I don't think it's necessary. So I did ask the manufacturers. I wrote to them and asked them if they had done the sort of studies to see if, a bit like with the other preparations, if you used it, gave it a bit of a blast to start with, could you then go down to using it twice a week like everything else? And they merely wrote back to me and said, if you prescribe it in this way, you'll be prescribing it off license. Okay. So I thought, well, you haven't answered my question, but so I prescribe it nightly for 28 days. I prescribe 2 lots for 28. They come in 28s, nightly for 28 days, and then twice weekly, in brackets, off license. And it does work very, very well. There's no doubt about it. It works very well.
And is it correct that if it gets prescribed postnatally, because we often, as physios, when we do a postnatal MOT, do notice that women have urogenital atrophy, and especially if, it can, after having a baby, returning to sex can be quite a big step, and then it's uncomfortable on top of that. But that's not licensed in the UK. Is that correct for postnatal?
It's not licensed, but I always write just off license.
Yeah. So most GPs seem to be happy with that as well. It's Karen, do you have any personal menopause experience that you're happy to share with us?
Oh, goodness me, I've never been asked that before.
Any lessons for us to learn?
Well, I don't think I do really, but not that I'm being shy in any way, because I have taken hormone replacement therapy. I took it for a number of years, and then for one medical reason or another, I didn't continue to take it systemically, but I certainly do take it vaginally, and I can't imagine not keeping that area of my body healthy. I just can't imagine it.
No, I think I'm definitely with you. Until my dying days, I will use local vaginal estrogen. And I think sometimes we see so many women in clinic that the GP after a few months will also say you can now stop.
Oh, it's ridiculous.
Yes, but it's a long-term treatment.
Yes.
Obviously, it's a bit like an overdraft. First, it takes quite a while to have money in the bank, and then you have to make sure you keep the money in the bank. Why go back in the overdraft?
Yes, yes, absolutely. And I definitely do see a number of women who shortly after stopping their hormone replacement therapy in whatever form it was, coming with worsened uterovaginal prolapse.
Yeah,
definitely I do. I have had 2 ladies today who have had hysterectomies in the past, and now their vaginas are completely turned inside out. Literally in one clinic, 2 ladies, one only 68. I mean, really, really difficult. The other one quite a bit older. And the tissues just looking really, really fragile. They should never have stopped. They'd had hysterectomies. There was no reason for them to stop at all. They could have carried on with a systemic estrogen forever.
Yeah. And most certainly local vaginal estrogen. Well, you mentioned earlier the plumpness and the recall of the collagen. Why wouldn't we want that vaginally?
Yes, absolutely. And even if they had developed some prolapse, then at least the tissues would handle better surgically and heal better surgically, even if they did need to proceed to having a repair, as these women will, because of course you can imagine anatomically, if you're a pelvic floor physio, that if the bladder is pulled down and is outside the body, the ureters too will be outside the body. And so of course it is a cause of back pressure on the kidneys and post-renal failure. So, you know, it's of material importance, quite apart from the fact that it's pretty degrading and awful to have to sit down and have your vagina exteriorized. It's really terrible for them. I feel so sorry for them.
Yeah, no, absolutely. And it's, you know, I think if I be an activist at anything, I probably will be topical local vaginal estrogen. And make sure that women will, I'll go on a demonstration for that.
Yeah,
definitely. I think that, well, Karen, what's the one irk that you might have about the menopause and how we talk about it, especially considering sort of more recent media attention there has been?
Well, I think it is going to. I don't want there to be a World Menopause Day. I really don't. I didn't even really want there to be an International Women's Day in a way, because I just think that every stage of women's lives should just be normal, optimized. I'm as passionate about girls' period problems and not having time off school for that. It should be normal. Everything should be normalized, optimized and normalized. So that's why I hope that the Adora app will come in. Yeah. But it is really important that it's not sensationalized. I don't like the razzmatazz around it. I don't like endless costly products on sale. That worries me and bothers me, and it bothers me from the I'm a socialist at heart. It bothers me that it's only accessible to people who can pay large sums of money, and I really don't like that at all. I want it to be normal. I want it to be normal that women, when they go to their GP aged 45 with a chest infection, that the GP or the health professional, whoever it is, practice nurse, says, now 45, you're still having periods? Yes, great. But of course, good time for sort of starting to think about the next half of your life. And that's how I like to phrase it, being your best self for the second half of your life. But we've got to be proactive about it. Not pushy, not just informative, encouraging to say that it is going to be possible to be doing everything you want to do. If you think about, of course, diet and exercise are the most important of all. I accept that. I'm not saying that menopause per se or hormone replacement therapy per se is the answer, but really being proactive about women's general health. And HRT will play a role for some. Of course, we're also, the Davina effect has 2 bad bits to it, not just one, but 2 bad bits to it. First of all, I'm seeing far too many women of 42 having regular periods. There's they're perfectly, they've got a baby that's 2 years old. I mean, there's nothing gynecologically the matter, but they're feeling low or tired or whatever. And because it's had such a lot of publicity, they're thinking that it must be menopause, and it's definitely not. Definitely not. But it's very hard for GPs or anybody to say that. And of course, people get criticized because the women then say they were fobbed off or whatever. But I'm sure they're not being. I mean, they may at times be fobbed off, but that's not an example of it. And similarly, I'm also getting quite a lot of 70-year-olds whose menopause was 20 years previously, and they might be getting some sweats or something, and they think maybe now that HRT is going to be the thing for them. And there are some risks in starting HRT late, a long time after. And usually these ladies are a little bit overweight, not always, but usually. And there are other health things which could help them, which are not hormone replacement therapy related, really.
So I've actually seen an increase recently.
Oh, huge increase. So we've got to do it in a timely fashion. That's everybody on this call's mission, I'm sure, to try and educate and encourage good health in every aspect: pelvic floor, movement, exercise, diet. HRT can play a role, but it's not the be all and end all. And there are other non-hormonal treatments for women who, for one reason or another, cannot take hormone replacement therapy, which can be very good for hot flushes. Women who've had breast cancer, things like venlafaxine can be fantastic for hot flushes. I've got one other treatment hobby horse, if I may.
Okay. Yeah, please.
There's an absolute obsession with transdermal. I mean, we didn't have transdermal when HRT was first introduced. It's a relatively new development. But again, just because Davina slaps it on all over does not mean that it's the only way you can take HRT. And today, I've seen 2 women where I wrote on the blood test or on the scan request forms. I sent them off for a scan, and I wrote bleeding on no bleed HRT.
Yeah.
And if I had £1 for every time I've written bleeding on no bleed HRT, I would be a very, very rich woman. And usually, not always, but usually, this is what would be, they are using what would be called component HRT. In other words, they're taking gel and a capsule, or a patch and a capsule, as opposed to all in one thing.
So the gel would be the estrogen
and the capsule would be the progesterone.
That's right.
And it's more complicated.
Yeah.
And by definition, sometimes a woman can't remember if she took the capsule. And sometimes she'll run out of one and not the other. So it is just more complicated.
Yeah.
And anything that's more complicated is more likely to lead to mistake, and therefore lead the woman into a new problem. The bleeding and the scan and a hysteroscopy and a okay.
Yeah, all the worry and anxiety that goes.
All of that. All goes with that. 2-week rule referral or whatever, Yeah. And so there is, of course, a component transdermal, which is Everel Conti and Fem7 Conti. There are some patches that have estrogen and progesterone all in one, so that if you want to take it transdermally, do it that way. But really, the only people who really need to take it transdermally are women who have risk factors for deep vein thrombosis.
Yeah.
So yes, it's true that anything you take by mouth, whether it's a piece of cheese or a tablet, of course, it's absorbed from your gut. It goes through into your portal vein and into your liver. And I say to women now, of course, the liver is a factory. It's a very important factory. It makes things and it breaks things down. And in the context of, I'm sorry, I'm in the dark here. I apologize. It's all of a sudden got very dark. But anyway, not to worry. I'll put the lights on.
I can still see you.
I'm fading away here. And in the context of estrogen, the liver makes clotting factors. Yes, it's true. Yeah. And so when girls are taking a combined contraceptive pill, which is really potent estrogen. We don't seem to think twice about that. Not really. It's far, far, far more potent. Of course, there is a small risk of deep vein thrombosis. So women who are overweight, smoke, of course, if they've had a DVT before, or there's a family history of DVT, of course, they should take it through the skin. But women who have not, there really isn't any reason why they need to take it through the skin. So they won't.
It's also personal preference, like you're saying, if it's going to cause confusion and forgetting and everything else, why not go for a simple? Simple method. Karen, there's like hundreds of questions I could ask you, but I've noticed a lot of questions on the Q&A. So shall we hand over to Joe to join us, and so that hopefully we can cover some of the questions in the Q&A. But that, as always, is so informative and common sense as well, and clear cut, Karen. So thank you very much. Joe, are you with us? Where's Joe gone? Otherwise, I will start with some of the questions. Let's have a look. Let me start. Are there different, Karen, are there different HRT options following an early hysterectomy?
Well, following hysterectomy, of course, one has the great advantage of being able to just take estrogen. Years ago, people used to, at the time of a hysterectomy in a young woman, would put in an implant at the time of closing the abdomen, a little pellet, which will release estrogen over anywhere between 6 and 12 months. We tend not to do that these days, but I do still use implants occasionally. There will be some women, I've slightly digressed from your question, but there are some women who simply don't absorb from their gut and simply don't absorb through their skin. So I've got a woman at the moment, a 52-year-old woman. She went up with the number of pumps, went up with the doses but the level was just, she was still very symptomatic, and her circulating level was immeasurably low. So however much of whatever she was taking before she tried to take now, she was never going to achieve a healthy circulating level. So she's going to have an implant. So about 0.5% of women need to have implants. But the ladies who've had a hysterectomy, it's really pretty simple. They can just take estrogen via whatever route they want, really.
Yeah, because they don't need to protect, obviously, the uterine lining.
Exactly.
And that simplifies it as well.
Yeah,
Joe, can I hand over to you for the question?
You can indeed. I'm afraid I locked myself out because I was so busy scrolling through all of these questions, and I could hear you. I'm kind of going to try and do them a little bit thematically, because Karen, some people have asked really specific questions, which I'm not sure that this is the forum. I don't know how comfortable you feel on that, but so we'll sort of start with some of the more general ones, if that's okay. I think everybody's, well, not, we've had several questions saying, could you repeat the name of the topical estrogen that you particularly like? And somebody said, not Vagifem. Everybody's picked that up. Is there several people have asked for?
Well, Invagis, IMVAGGIS, Invagis is the in with your finger, melts in the vagina, so it gives some natural moisture, and it releases estradiol just the same as the other preparations.
Great. And there's been several questions about cancers in the family, precancerous cells. Can people, can you sort of summarize the situation with families where there's a history of cancer, or breast cancer, or other cancers?
Instinctively, women who've got a family history of anything, even if it doesn't have any actual biological scientific importance, they are more nervous, they're anxious. Of course, if it's there's breast cancer and breast cancer. There are women who have a BRCA gene and have had prophylactic removal of breasts and all of this, and those women will almost certainly not take HRT, and they will be probably guided to try something like venlafaxine for hot flushes, something specific for sleep, for anxiety, but they can still almost always unless they've had a breast cancer themselves and they're on an aromatase inhibitor, whereby they won't be able to take estrogen even in the vagina. But unless it's that particular circumstance, they will be able to take nourishment into the vagina. You mentioned precancerous cells. The cervix has no. That's having had treatment to your cervix is not in any shape or form a contraindication to using estrogen of any sort anywhere.
Okay, thank you. I'm now looking at, there's been several questions about topical estrogen and breastfeeding. Is it safe?
Yes, perfectly safe.
Okay, that was a nice quick one. And several on the ages of taking it. Some of people are postmenopausal, some people are saying, are you too young for it? So a general guidance on the age. I think you summed it up, you talked about the POI, etc., but I think we've got people across the age group asking that question.
Yes, well, premature ovarian insufficiency is a very specific, hard diagnosis. It's solid. You've had your blood test, you've got no periods, you had your blood test done, you've had them repeated 6 weeks later, your gonadotrophins, the LH and FSH are sky high, and that is it. Of course, just to be accurate, of course, things are never quite as clear as that. So within that group, there will just be a very small number who you can't possibly know who they are. They can't know who they are, who actually have a resistant ovary syndrome. So HRT, of course, is not contraceptive. That's important because their ovaries are just refusing to respond to the gonadotrophins, but there may still be eggs left, and so they may wake up. But that's so rare. Usually they certainly shouldn't hold out any hope. There's nothing that can be done to wake them up. It's just an important piece of information, so that if getting pregnant would be a disaster, then they need to take contraception. Okay.
Okay.
Sorry,
we didn't.
But then, of course, you move on to that huge group of people who have been fueled, particularly by the Davina-McCall effect. Huge numbers of women in their early 40s who they think they've got symptoms, and I've decided that the menopause is potentially, if we're not careful, it will be a stick to beat women with. Okay, a stick to beat them with. And I hope this is recorded, so I probably shouldn't use any choice vernacular. But
go on.
I can almost hear people saying, "Get yourself down a fucking doctor, get yourself sorted out." Okay, so I feel for women hugely when they're having sad, difficult times. But most of us know what sad and difficult times are, and it won't be their hormones. Of course, occasionally it will be, and I'm very able to help them to maybe do the experiment. Okay, I hear what you say. I don't honestly think it's that. I haven't got a test to tell me, but I mean, if you really feel you just want to give something a try for 3 months and then come back and we'll talk again, that's fine. But it's not always the answer.
Okay, gosh, I'm actually trying to find, they're getting quite specific now. So I was just looking for my next one. Breakthrough bleeding is coming up. I know you covered it when you talked about the composite, I think you called it. Component, sorry. So any sort of general guidelines on,
yes,
when it's good,
yes,
when it's not good,
yes,
what to look out for?
So the working rule, of course, is that if a woman is still having periods, even though they may not be regular at all, she may only have had 2 in the last 6 months, she must take a cyclical regime. Now, there will be women at 48 who have got really chaotic, ghastly periods. And in the same way as a 16-year-old might go onto the pill for ghastly, chaotic periods, a 48-year-old might go onto a cyclical combined regime, in which case Yes, take a tablet, for God's sake, take a tablet. You know, it's just ridiculous to think you're going to be counting the days for your Utrogestan and doing this and doing that. It's just not real life when you've got a busy life. So just take a packet which has got 14 days of just estrogen and 14 days of estrogen and progestogen. And that should be able to superimpose some rhythm on the uterus, on the endometrium. But you've got to make a careful decision, think about it carefully, as to whether you're hearing about abnormal bleeding that, is there something going on here? Is there something going on? Is there a disease process going on within the endometrium? Should I be arranging for this woman to have an endometrial biopsy? Or could I just for 3 months give a trial of a cyclical combined HRT regime, and then if it doesn't settle into a nice, clear, obvious rhythm, then think again and send for a gynecological assessment.
Great. So can I just skip in here, because there's one question I'd love Karen to comment on.
Yep.
Patients often ask me as well in terms of progesterone. It's become quite popularized to prescribe it in certain parts of the world for mood and sleep issues.
Well, there is some proven benefit to sleep, but for taking progesterone by mouth, there is. In as much as in the liver, it is converted, one of its breakdown products is a GABA receptor stimulant, which GABA receptors are very important for sleep. So there is some advantage to that. And very occasionally, if I have a woman who's been hysterectomized, and so she's just on estrogen, she comes back and, 6 months later, she's feeling fine, except she just really still isn't sleeping well. Not to do with sweats, but she just still isn't sleeping well. I might give her a trial of natural progesterone, even though she doesn't need it for her endometrium.
Interesting. That's because, that's something that's not always clear to women, I think, in terms that's really helpful. Joe, any?
Who's going? There's so many. I'm scrolling up. Just a sort of taking a slight detour here. There's a lot. Someone said there's a lot of talk about the physical signs of menopause. What about someone's got the more mental and psychological impact? How does one manage that?
Well, maybe just I'll touch on another rather topical subject, which is there is a huge increase in diagnosis of ADHD in the adult population. And if you were to Google the symptoms of ADHD, there's a huge overlap with possible mental well-being symptoms of menopause. So it's very difficult. And of course, there'll be a huge overlap with actual reactive depression or actual just anxiety disorder. It's particularly difficult, I think, when people have had anxiety or depression as part of their background health. I mean, I feel strongly that women who have that as a part of their background health, they shouldn't be denied HRT if that's what they want, because they might be just holding their own on their sertraline or their citalopram, and now this extra straw is just going to rock their equilibrium. So I'm very open-minded about introducing HRT for women who have that as part of their mental health picture, their general health picture. But what I do feel sad about is if women they're really blinkered about they don't want to entertain the idea that this could be that, and I phrase it that some of the chemical agents, you must be open-minded to the fact that some of the chemical agents that send the message from this part of your brain to this part of your brain, which controls your mood, that might be depleted. And HRT is not going to replenish that bit of your neurotransmitter agent, but a medicine that's designed for that might well do that. So let's be open-minded, and if you see what I mean.
Yeah.
Okay, Christine, there's endometriosis come up several times. I've just tried to skim up and down the the questions, and I think someone's just said quite simply, HRT and high blood pressure, endometriosis, a benefit or not? Oh, I think, sorry, that's 2 questions. Endometriosis, let's go to that one. Benefit or not? And we've had several quite specific individualized questions. So I just wonder if we can address it as a sort of a general subject, if you don't mind.
It's not a benefit or a problem for endometriosis. But the important point is that even though somebody may have had their uterus removed because of endometriosis, they may have had their ovaries removed because of endometriosis, so that they go onto hormone replacement therapy, even though they've had their uterus removed, they are not suitable for estrogen alone. Because estrogen alone will stimulate endometrial cells where'er they be. And even though you might have had the organs removed, there will still be spots. If you've got real good going endometriosis, there will still be spots of endometrium around the pelvis and maybe elsewhere in the body. And so those women must have a combined HRT.
Okay, I think apologies to anyone who we've not covered. Some of these are so specific. Christine, is there anything that you can see that we've got?
There's a question about DEXA scans.
DEXA scans, yes, I thought that
to get referred to or reported on. I believe if there's a risk group and you're not on HRT, a DEXA scan should be possible to be organised if you fit into that, and because they're not expensive and they're safe.
Yes.
How do you get one then, Christine? Is it something
just keep
privately
knocking your GP's door, and find a GP that will respond. But obviously, they do need to do an assessment and see if you need the screening, depending on your risk factors. Is that
okay?
Yes.
Yeah.
Okay. I think we might just have to wrap it up. And again, apologies to anybody who didn't get their question answered. Drop us an email and we'll see what we can do, but we can't promise, I'm afraid. And it's quite difficult for you to give very specific individualized advice, isn't it, Karen, in this context?
Well, it always is, because there's always far more to an individual story.
Yeah.
But then, of course, you could always immediately wind up the thing, and they could go to Google and they could Google Dr. Morton's medical helpline. They could come
exactly. Thank you. That was I was slightly going to link to that
incredibly well. It does work. So
it does work as we're personal users. So thank you to everybody who has shared, because there were some really, really sort of detailed questions, and I'm really sorry we haven't got around being able to answer them. But thank you to everyone for your questions. Thank you to Karen, and thank you to Christine. Beautifully hosted as always. I'm now going to hand over to Anne, who's going to close for the evening.
You. Yeah, sorry everyone who haven't had your questions answered. We knew this was going to be a really popular event, and it has been a record-breaking one for attendance. So don't want to take up any more of Karen's precious time. We always love having Karen, but we think she should go back to her little pug.
My dog.
So I just want to quickly let everyone know about our next webinar in April. So we're joined by Cassandra Hawthorne, an acupuncturist with a specialist detailing in menopause, oncology and pain management. It's titled A Complementary Perspective, and she will be talking about Chinese medicine. And as it's a spring webinar, we'll be covering the second spring, as it's called in Chinese medicine. It's also part of CPT training for our menopause movement big course, and we'll be looking at the difference between Chinese medicine and the Western perspective, and what is the common ground, how Chinese medicine looks at different symptoms, including prolapse and leakage, and how it can be used as an alternative complementary management to HRT. And we'll also be joined by Sarah Thomas, who is a menopause movement trained yoga teacher, and she'll hopefully be giving us a yoga nidra experience. And my dog has just come up to join us. So yeah, that will be on Monday, the 24th of April at 7 p.m. So I want to thank everybody who's joined us across the globe, wherever you are. I know we didn't get to see everybody where they could join us in the chat, but anyway, thank you so much for joining us. Once again, thank you so much to Karen and Christine and Joe, and hopefully we'll see you all again in April. Take care.